Good afternoon, everyone. Thank you for choosing to spend your lunch hour with us today, and welcome to our second webinar of 2021 and our quarterly webinar series presented by the Business Innovations Department at Androscoggin Home Health Care and Hospice. My name is Jillian Netherland, and I am a member of Androscoggin's Business Development Team, along with Lisa Kaye, Sarah Educator, and Sean Hackett. Depending where you're located, you may know one or two or all of us. While our webinar series is new, our face in the community is not. Androscoggin was founded locally in 1966 and today is the largest not-for-profit home health and hospice agency in Maine, serving nearly 450 partner affiliations and more than 185 communities. Because of our nonprofit status, we are able to provide more than $1 million in care each year. We are proud to offer a comprehensive suite of services, including home health care, hospice, and palliative medicine. What this means to our partners is that we are able to provide a seamless continuum of care for your patients as their needs change. These webinars are to serve as a helpful educational resource during this time, being unable to connect in person as we once did. Today's topic is palliative medicine, chosen due to the option it provides patients for improved quality of life, as well as symptom and pain management, while still utilizing curative measures. Our goal today is to show you what we are doing and how we can help you care for your patients while providing a quality of life that is free of pain and full of meaning. Please know that this webinar is for you, our partners. We encourage you to ask questions as you have them through the chat box so we can be sure to address them and get you the answers you need. To make sure we are presenting our webinar in a way that speaks best to our audience, we are going to begin with a question for you to answer via multiple choice on your screen. Where are you joining us from today? Oh, looks like we're pretty split between health systems and skilled care facilities, with a few of you joining us from private employers or other organizations. Thank you so much for taking the time to share that information with us. That will definitely help us tailor this presentation to your needs and where you're coming from. So speaking of, here to discuss all things palliative medicine are our subject matter experts, Dr. Vance Brown and Kathy Amsden. Vance Brown, MD, is a graduate of the Yale University School of Medicine. He is board certified in internal medicine, family medicine, and hospice and palliative medicine. Dr. Brown has extensive background and experience in academic medicine and has served additionally as a system chief medical officer, hospital CEO, and health system CEO. He is interested in developing better care models for patients with serious illness and improving services to rural communities. Dr. Brown has been serving as the Chief Medical Officer of Androscoggin Home Health Care and Hospice since October of 2020. Katherine M. Amsden has been a practicing social worker for more than 40 years. Her experience in school social work, mental health systems, and private practice lay a strong foundation for her current specialty in medical social work and palliative medicine. She joined Androscoggin Home Health Care and Hospice in January of 2012 to further the development of palliative care and leads the home health, hospice, and palliative teams of social workers, chaplains, and navigators. Kathy has earned national certification in both interactive methods of psychodrama, sociometry, and group psychotherapy, as well as hospice and palliative care. She has extensive and specialized training in a trauma treatment model of care, has taught graduate-level social work classes and group work, and won the Innovators Award twice in her career, once in 2009 for her album Awakening and the incorporation of therapeutic music, songwriting, and playwriting in psychodrama and psychotherapy, and a second time in 2021 as Employee of the Year at Androscoggin for her contributions on workforce well-being in response to the pandemic. And now, to discuss all things palliative medicine, I'll turn our webinar over to Dr. Vance Brown.
Thank you very much, Jillian. And thank you all for spending some of your time with us on a precious Maine summer day. We really appreciate your being with us. Today we're going to cover things similar to what I think I learned in 7th grade about in journalism class, trying to answer the who, what, where, when, why, and how overall. So who benefits from palliative medicine? what really is palliative medicine and palliative care, and how is that fundamentally different than hospice? Where can patients receive palliative medicine services? When are patients more appropriate for palliative medicine and or the hospice benefit? Why, at the end of the day, is palliative medicine and palliative care beneficial to patients and providers? And how do you start a goals of care conversation? And how might you make a referral to others to help you along in that process? So a lot of the palliative medicine, we're going to talk a little in a few minutes about the differences between palliative medicine and hospice, and that's a very important takeaway. But it's really important to realize that a lot of the growth and development of palliative medicine as a specialty overall has really been very tightly connected to the growth and development of hospice services here in the United States. The real founding drive for the hospice movement really came from a very famous and remarkably visionary woman by the name of Cicely Saunders, who was started her career as a nurse in the United Kingdom, eventually went on to medical school, and became an incredible advocate for people who had serious illness and for better care of patients with serious illness throughout the continuum and the process of their death. She started really the hospice movement, the modern hospice movement, largely in the United Kingdom, and came to the United States and started to lecture on this. So the first lecture being delivered at Yale in the late 60s. No great surprise that inspired a lot of inspiration. Inspired a lot of movement overall. And the first hospice was founded in Brantford, Connecticut, which is about 10 miles away from Yale, in the early 70s. Eventually, this seemed to catch on where the HCFA, the financing arm of Medicare, started to develop demonstration projects at multiple hospice programs in across the country. And eventually, by the 80s, had started to really actually define who would benefit from hospice and who could be included in receiving hospice care, which is really a landmark overall. By the early 2000s, one of the important things that happened I think in the physician world is that the American Board of Medical Specialties finally created a subspecialty in hospice and palliative medicine. Really, I think, codifying the fact that this is really, really important work and requires medical attention of people who are trained in that particular specialty area. Certainly, palliative medicine, along with hospice, has continued to grow exponentially across the country and grow exponentially here in Maine. There are now individual training programs for physicians and clinicians in palliative medicine here within the state, and lots of opportunities for training moving forward in multiple different specialties, similar to social work and advanced nurse practitioners as well. So it's really evolving overall as a branch of medicine. One of the things that's really important for us to emphasize to you, and we will repeat this probably a couple times to make sure that we get the point across, that hospice itself is part of the continuum of palliative medicine, but not all of palliative medicine is hospice. It's really an important principle that sometimes can get very confusing for folks. This slide is really what I'm going to call core beliefs that we have for patients in palliative medicine and those who are receiving it. First of all, at the bottom that says early involvement and intervention of palliative care services help to improve overall quality of life for patients and families facing serious life-threatening illness. That could be self-aggrandizing, perhaps, but I'll say that in reality, there's a lot of medical literature that really have begun to scientifically document the benefit of palliative medicine in terms of relieving pain, anxiety, and helping others. And ironically, for palliative medicine intervention and consultation can sometimes prolong people's life if we can improve the quality of their life at the same time. People sometimes have the opportunity and the will to live longer. But these core tenets are really important to discuss, at least at a high level. First of all, we believe in whole person care. The patient or the individual that we're working with is a very complex being, certainly physiologically complex, and may have very complex pathology and medical needs, but also somebody who's part of a family, somebody who's part of a community, somebody who's part of cultural traditions, somebody who has strong beliefs about what they feel should and shouldn't be done, and sometimes has very deep and meaningful spiritual needs that have to be taken into consideration as we work with that person, and trying to get a 360-degree view, for want of a better term, of who that person is and how they are going to interface with us is really, really an important part of the work that's done in palliative medicine. The second core tenet really is that we operate, as we do in hospice, in palliative medicine, through an interdisciplinary team, meaning almost no one has the expertise to have a 360-degree view of an individual, nor the time to be able to do all of that work. So an interdisciplinary team is usually going to include a medical provider, a physician or nurse practitioner, and also is going to include members of our social work team. And you'll hear from Kathy shortly about some of the work that she and her colleagues do, but also involve access to folks who have expertise in spiritual care as well. The third kind of core tenet that's really important for us is patient choice. So, as long as the patient has capacity to make their own decisions, or to make has capacity to make limited decisions around some of the areas of preference, we're going to do what we can to, by and large, advocate for that. Meaning, even though we might disagree in our heart of hearts about a choice that they might make, as long as we feel it's not harmful to the patient, we're going to generally follow the lead in the direction of the patient and the family as they provide that. Part of our goal is to work with people to make sure we understand what those desires are, and sometimes to make sure that they're making those decisions based on the best information available as the situation changes. And then another core tenet is that this care really should be delivered in diverse care settings. And our team certainly has worked pretty hard across the continuum. So we provide palliative medicine services in acute care hospital settings, in consultation with the medical staff of some of our local hospitals. We also do a lot of home based palliative medicine consultation and care. And increasingly these days are using video platforms for that with the rise of the pandemic as well. And it also, I would say, works quite well because a lot of these issues are ones that require deep discussion and sometimes involving other family members. So as I mentioned, trying to make sure that you walk away with knowing what the difference between palliative medicine and hospice is, that's really an important part of what we wanted to talk to you about today. For starters, hospice, at least for Medicare patients, is a really defined benefit and is authorized by Medicare regulations, where palliative medicine actually isn't necessarily a designated Medicare benefit or plan. So when we see people in palliative medicine, it doesn't mean that Medicare won't pay for that service. It just means that we bill Medicare on a fee-for-service basis for that work, what's called Part B billing overall. Whereas the hospice benefit is really a very comprehensive benefit and is tightly regulated by Medicare. Patients who don't have Medicare as an insurance, by and large, are generally also covered for hospice benefits under their insurer, and the coverage usually tends to follow and mirror that has been established under the Medicare program. So eligibility for hospice, it's really important that we recognize that patients who are eligible for hospice have a terminal diagnosis and a prognosis of 6 months or less. Sometimes it's multiple diagnoses that tie together to actually lead us to conclude that their prognosis is relatively short. But that's a criteria that they need to have an estimated prognosis of 6 months or less. I think in all sense of humility, anybody who has to do prognostication recognizes we're far from perfect at this. And when a patient may have lived longer than 6 months on a hospice program, doesn't mean that they're exited from the hospice program. It means that we're just asked to reevaluate on a relatively continuous basis about whether we think their prognosis still is in that category. Eligibility for the palliative medicine world is quite different, though, in that patients of any age and any stage of illness are by and large eligible to receive palliative care. So palliative care can oftentimes be very helpful and useful in a patient who may have newly diagnosed cancer, even though their cancer could potentially be curable. That might be a patient who still might benefit tremendously from palliative medicine in terms of helping support them through difficult decision making and through complications and challenges associated with their treatment program. The services that are provided under hospice program is a very comprehensive benefit. So by and large, it covers and requires certain specific things of a provider, one of which is to have an interdisciplinary team where the patient is discussed collaboratively amongst multiple disciplines. And by and large, the medications that are related to the patient's qualifying diagnosis for hospice are covered. Durable medical equipment is also covered, and all hospice programs that take care of Medicare patients are required to have bereavement services in place to help take care of the family and loved ones afterwards. The palliative medicine thing that's important to realize is it's really not a substitute for hospice, or it's not hospice light, for want of a better term. We really can't provide necessarily all the same set of comprehensive services in palliative medicine as we see as a requirement in hospice, and do, as I mentioned, work really more on a fee-for-service basis. And then probably the most important difference for all of your folks' perspective in these two is that in hospital, when patients and their families make a decision to enroll in a hospice program, it doesn't matter. They don't necessarily have to abandon all of their medical therapy and become comfort measures only. It means that basically what they're doing is abandoning real attempts to treat the underlying primary problem. So for instance, that might mean a patient might continue some of their important cardiac medications if we think it's going to contribute to their comfort and well-being. But the patient wouldn't necessarily go back to the heart to have a coronary artery bypass surgery done or to have a cardiac catheterization done. So it has to be really lined up with their goals of care, and those goals have to be ones that really are focused primarily on their comfort overall and viewed at through that lens. The benefits in palliative medicine are defined and authorized really by the more specific criteria of whether Medicare or the private insurer is going to cover some of the particular services and other benefits that we're trying to provide for the patient. So having a long-standing interest in clinical medicine, I want to introduce a lady to you by the name of Betty Lou. Betty Lou, actually, in case you have any relatives or friends by the name of Betty Lou, she's actually just a compendium of the patients we might see in palliative medicine. So she's not a real lady, but she rings pretty close to the heart, I think, for many of us. So she's an older lady, has a history of advancing heart failure, and also has multiple other medical problems, including chronic kidney disease, which oftentimes is really bedevils the patients who have heart failure. She's being been in a hospital for an episode of congestive heart failure, and she's being transferred out to a rehab facility for the second time in the course of a year with symptoms of heart failure. Typical of many of our patients, she had a death recently of a loved one. Her husband died in the hospital about a year ago after suffering from a debilitating stroke. And needless to say, she's got concerned family who are involved in her and very concerned about her well-being and how she's going to do, and is she going to be strong enough to be able to return back to living as independently as she had been previously. She's a patient that every time the doctor who admitted her to the hospital had asked her the question if she wanted to, what she wanted at the end of life, she would say, I want you to do everything. I want to be resuscitated. And her family validates she's a fighter. She really wants to continue to live. But of note as well, she hasn't been eating particularly well. So probably some of the patients you could all identify with today. So to help take us through a little bit how a palliative medicine team might approach a patient like this, my colleague Kathy is going to lead on here for the next section.
Thank you, Vance, so much. So when we think about palliative medicine, and we think about it from a couple of perspectives, and I'll get into this later, from the primary palliative medicine is something that we all need to, a skill set that we all need to develop, and then specialty palliative medicine. So it can be a continuum of care that these benefits can be derived from. So when we do have a serious illness, when we're diagnosed with something that we're told is possibly life-threatening, we often need an extra layer of support. It's hard to navigate the many decisions that have to be made, to understand the medical language, to just trying to sort through all the feelings and all of the practical aspects of care. You need that extra layer of support. So that's the idea of palliative medicine. And I think when you're trying to describe to a patient and you're trying to think about, well, I think you might benefit from this palliative medicine, these are some of the language that you might use. So you might say to someone, the palliative team would provide you an extra layer of support to help you navigate some of these decisions and some of the information that you need to understand about your disease. So that's that patient education and family education that they might be able to provide you, so that you understand things better. They might help you to understand and communicate your goals of care, what matters most to you, what helping you understand the choices that you might need to make, but how does that relate to and align with what your goals are? So helping sort that out. There might be some very symptoms that need to be managed there, and so palliative medicine will provide that aggressive and proactive symptom management, because the point of palliative medicine is to have quality of life. We want to focus on quality of life. Oftentimes there's a lot of different providers involved, a lot of different moving parts. And so communication and the collaboration of services are something that our providers frequently assist with. Advanced care planning documentation is absolutely critical. It does say what the goals of care are for that patient, what they would want, what they would not want, who's going to be the power of attorney for that patient if they couldn't speak for themselves. So getting a lot of that documentation done is absolutely critical. We really like to talk about the importance of navigating through the co-care trajectory. So being able to assist at different stages and different phases. And so that navigation service that we have our navigators assist with is absolutely critical for our patients, so that they receive a continuity of care across the care. And the focus is also on getting the right care at the right time based on the patient's goals of care. So there's other benefits as well that are kind of more in relationship to that outcomes of patients that and providers might think about some of these things. So with that continuity of care through the whole trajectory of the illness, we really believe that a benefit is to move a conversation upstream. The sooner we have a conversation, the better. And we can have an early identification of a serious illness to avoid what we call crisis-driven care. So often, working in the ICU over at CMMC, when I was a palliative care social worker over there, we would have so many cases of people coming in and so critically ill and unable to, we don't have advanced directives. We're calling the PCP office saying, do you have any? We just need to know because she can't speak for herself now. And it's a crisis, and the family is in the middle of not knowing what to do or what their loved one would want. We want to avoid that crisis-driven care. So that those conversations, that early identification, having things documented across the care settings and communicated, and really focusing on having different medication management and coordination of care across the trajectory of the illness. Also, we believe that palliative medicine, and as Vance was saying, there's many studies now and research that's going on about how introducing palliative medicine into the picture will help reduce hospital visits, help to reduce lengthy hospital stays, reduce ED visits, especially in that last 6 months of life. If you can get somebody in the last 6 months, I'm going to even stretch it to a year. We've had some extremely good luck with, and we're watching this carefully. We're measuring this. We're gathering data all the time on this. And as long as we know what people want, and if we're really doing good with avoiding visits. Those navigators, when Lori, gets a call from somebody and has a relationship with somebody, she can often, she's an RN navigator, she can often sort out what the symptom is. She can call the provider and have the provider see the patient to resolve the symptom management, versus the other option is, I don't know what to do, so I'm going to go to the ED. So I think those are really important pieces. The whole ICU utilization, especially in that last 30 days of life, I have memories and pictures in my mind of those days, and it's not really a good end of life experience for most people. It's traumatic for the patient and the family, and so we'd like to reduce some of that if that is the patient's goals of care. Unwanted tests, surgeries, procedures, treatments, reducing those. The costs of managing symptoms in a patient's home is much less than in a hospital setting or an ED room. Basically, we think that palliative medicine increases the chance of having a good end of life experience. If it is the last chapter of your life, if we've had these conversations, if we can talk about symptoms changing, and we know what a person's wishes are, and endings matter in a lot of ways. They matter for the family, for the bereaved. When we've had a good end of life experience, it's an honorable time, it's a spiritual time, and we really want to improve those outcomes. So what are the key pieces of this? It's just a good review here. So what are the things that you need to be thinking about doing as a primary palliative care person? You need to start those conversations sooner. Remember, we're trying to avoid that crisis-driven care. You need to know that a patient goals of care conversation really matters. And it matters because we're more satisfied as a patient if we've been heard, if we know that somebody knows what we want and what we don't want. It really matters to your relationship to have when people feel understood. And it matters to the family when they know what to do. So those conversations matter. So really developing those skill sets are very critical, and referring to the specialty team when it's complicated. Having a plan, we know, reduces anxiety. The plan changes, absolutely it does, but having somebody to talk about that plan also, along the way is very helpful. And we're talking about a plan here that's who's going to take care of me, who's gonna get my food when I can't get it for myself, all the way to what's going to happen, what do I want and not want if I have to go to the hospital. So having that plan matters. Having that plan documented matters, so that it's on an advance directive, it's on a pulse, it's a DNR, it's communicating those wishes and making sure those documents are going across the care settings. It is so important. I cannot tell you how many times, as I said to you earlier, my ICU cases, that I was on the phone trying to find advanced directives from primary care physicians' offices. So absolutely, or having those in the skilled nursing facilities, or having them in the nursing home, all of those are absolutely critical to have on hand, easy to grab, to know where they are. We really do want to increase the quality of life and that chance for that better end of life experience in that last 30 days. And it's also very costly. If we're doing things there's a human cost and there's a financial cost to that. So really being able to improve that is part of that skill set that by doing this, you're absolutely helping to make progress on this. Thank you. So advanced care planning, the whole importance of having conversations about the types of things that you might be facing for life-sustaining choices. Would I want to be intubated? Would I want to be put on the dialysis machine? Would I want CPR? Would I want 2 or 3 antibiotics? Would I want to be in the ICU at all? Those kinds of things, understanding all of those. Would I want tube feeding? Would I want hydration? And so really understanding that we have in advanced care planning, we're detailing those conversations so that people understand what it is. There's a lot we can do now, a lot. And a lot of people out there have no idea what this language means, or they really do not know what all of this, when they say do everything, that's a lot, because we really can do a lot and we can keep doing it. And I don't think people really have an understanding of that. So advanced care planning is really getting down to the education around that. And deciding what types of interventions you would or wouldn't want if you were to be diagnosed with a life-limiting illness, or if you have one, you might have a one choice now, but you might say in your advanced directives, but if things took a turn for the worst, I would want this. So being able to really spell that out in the advanced directives is very helpful. And the main advanced directive has a page 8 that has lines and ability to write that all in, and they're guiding statements for your loved ones. They're guiding statements for your power of attorney, so that people know what to do when they're faced in that crisis moment, if there is one. So it's also very clear that those guiding statements have personal values and beliefs written into them. And completing those advanced directives and putting those healthcare wishes into writing. The other part of this is really, who would you want to speak for you if you are too sick to speak for yourself? Oh, my husband will do it, and then nobody writes these up. Or my son will do it, and nobody writes this up. And so husband and son are absolutely lost, and the conversation hasn't happened. Or maybe if you don't do it, it's now your husband's gone, like in Betty Lou's situation, and she hasn't redone her advanced directives yet. And so her son is falling to her son now, and he has no idea what she would want or not want. He thinks he does because she's a fighter. But also there's a surrogate decision-making law that it will fall to that. And sometimes you may not like the order that the decision maker comes in with that surrogate decision-making law. So naming a person is absolutely critical with that. So when you think about moving forward with this, you're really thinking about starting that conversation. And it often starts with asking that question: what is your current understanding of your condition? So making sure people understand what's going on with them. What are some questions that you might need answers to so that you can make a plan and decisions for yourself? speaking to the next piece is to really just listen to what matters most and to ask that question. So what matters most to you at this point? What would matter most if things were to take a turn for the worst? We really encourage people to have these important conversations, and we call it advanced care planning. And we can offer the resources to help with this. So what are those resources that you might offer? Well, there's some things online. We're going to give you some resources of how to get to those on our webpage. Here at Androscoggin, we have advanced care planning, and underneath that, we have a lot of different websites that you can visit. There are excellent tools out there to work with this. So those you can refer to your families and your patients. It might be that they're in home care and you have you ask for the social worker to help with advanced care planning with advanced directive. It might be that you have a social worker in your facility or in your hospital and or your doctor's office, and maybe you'll refer to them. But it's also true that you may refer to the specialty palliative care team. So those pieces are just ways to there it is, that specialty palliative medicine team, because you may decide that this is too comprehensive for me to have this conversation right now, or I think this is too complex. I need somebody to do a really good interdisciplinary assessment. I think that there's some management of some symptoms that's coming up. I like the idea of that navigator following a bit for a while to see where this is going to go. And being able to assist with that conversation. I think they're kind of all over the place with their goals of care, and they're not on the same page, or they don't really understand the illness well. I think it's going to take a more in-depth conversation than my 15 minutes that I have with them. So I really also think there's so many things going on that we need to have somebody collaborate and coordinate some of this care. So that's when you think about the specialty palliative care referral. So who do you think about? I want you to think about, number one, what's the person's serious illness diagnosis? That's really critical, is that primary diagnosis. And then look at what their functional status is. Betty Lou, well, she's not eating so good, right? She's starting to have a few symptoms. She's had, maybe there's a little bit of confusion now and then. We'll see what happens to her with her symptom management or symptom control. It's an overall declining status that's due to the advancing illness. You're seeing changes like this that are due to that advancing illness. And you know, another thing is called the surprise question, and it pretty much says, so would you be surprised if in the next year or so some of these progressive symptoms could lead to the end of life for this person? Those would be people to make that referral. So Betty Lou, after a few weeks of slow progress in that skilled rehab unit, some of you know these folks really well that are a part of this audience, Betty Lou gets a little stronger and she's able to get up and be a little more independent, but she's saying, I want to go home. I just want to go home. And her family is supporting this decision. And she goes home, and her son is calling you, if you're a primary care physician out there, with concerns that she's not doing very well. And you as the primary care physician say, let's get home health in there, and maybe the skilled rehab referred to home health also. But let's get that home health care in there to keep monitoring Betty. Let's see if the physical therapy would help her some more. Let's get a telehealth monitor to really be able to look at her vitals and a few other things that those sweet little machines do. But you're basically, she's really not, she starts to not make so much progress. And now she's starting to get some other symptoms. Yep, that swelling starting in her feet. She's starting to retain fluid. And she's getting kind of short of breath, and she seems to be tired a lot, has a hard time getting up. And so her son is feeling like, boy, she's saying she doesn't want to go back to the hospital. She doesn't want to go back to rehab. And he thinks, well, that's pretty odd. She seems to be giving up. But yet Betty Lou's still full code. You as a primary care physician have adjusted some medicine. And another piece that's happened is your home health care team has identified that she is a seriously ill patient who would meet several criteria for palliative medicine. So there's a decision made that she'd be appropriate for a consult. There's some questions. There's our questions. So the questions are related to what you think you would want to ask from the palliative medicine team to accomplish during this consult. Okay, let's see. 92% say all of the above. Well, aren't you a smart little group out there? Because that is absolutely true. So you can see that, yep, she better have a goals of care conversation. Some of you liked that one even more than anything. Might be important to discuss that, her DNR or her full code status, and look at those symptoms of shortness of breath and update those advanced directives because her husband's still listed as #1. So absolutely correct. All of the above could be accomplishments made. Very nicely done. All right, Vance, I'm going to turn this over to you.
Great. So I'm going to just briefly describe a little bit of what the structure of where we are organizationally about palliative medicine and give you an introduction for that. So since coming on board in fall of last year, some of my work has been involved in helping to build and launch the Maine Center for Palliative Medicine. This is actually really largely the initial vision of Ken Albert, who's the Androscoggin CEO. Ken is a nurse and an attorney by background, so I've been really committed. Been an ICU nurse for a while, really committed to the principles of palliative medicine, the growth of palliative medicine as something very essential for the better care of patients. And so we've put together a Maine Center for Palliative Medicine. It's really kind of getting launched onto itself. We've had a palliative medicine service line or provider group now for a couple of years, and those folks have been doing good work. But our goal is really to take this to the next level and really to be a trusted leader along with other colleagues here in the state where we bring technical expertise and also continue to work on the education, primary education, as Kathy mentioned, as well as take part in the specialty education of medical professionals throughout the continuum to help improve the care of patients with serious illness. Our goal is also to eventually serve as a conduit for some of the efforts in research in palliative medicine. And as everyone here is probably aware of, that's a real challenge in a rural state, but we hope to be able to push that vision out as we move forward. We do have a very comprehensive program that's already built, and I mentioned some of it earlier in some of our discussions. So we've got hospital-based partnerships and clinic-based partnerships in some of our hospitals as well. We have a very busy community outpatient palliative medicine program. We've got about almost 200 patients now that we're following on a continuous basis in palliative medicine. And are getting lots and lots of referrals for new patients coming in. As I mentioned before, we're able to offer a lot of our services via virtual health or telehealth, which has been a great boon during a really tough period for all of our lives over the course of the last year. Hospice agencies, one of the things I didn't know before I started doing some of this work a few years ago, hospice agencies are actually required to have a lot of their services provided by volunteers. So we have a really great volunteer program overall in the organization, and access to those folks to help power our program. And then, as I mentioned, education and training is a super important part of our mission moving forward. So this is my favorite slide. For those of you familiar with Androscoggin, know that we have a very large hospice program. We have the largest provider of home health services in the state. We have a dedicated hospice house and are involved with inpatient care in some of the local hospitals, and have a very good transitions of care program for patients whose care may be moving across the continuum. A great team of folks to follow those folks and help support many of them with difficult psychosocial needs and challenges. But palliative medicine is, I think, emerging in our organization as being a centerpiece that helps interconnect all those different services that we're able to offer patients. And we're constantly working in collaboration with our colleagues in these other disciplines to be able to try and figure out, as Kathy said, how to deliver the right time, or the right care at the right time in the right place for our patients, regardless of how that is accomplished. So one of the things that I would encourage you, for those patients that you feel might benefit from palliative medicine referral, this is just like doing a referral for medical subspecialty or surgical specialty issues. Think of it much the same way. We're information junkies, for want of a better term. So the more information we have to start when we start to see a patient, including some of the basic demographics of diagnosis, medications, kind of a summary document that might include a history or recent history or physical or discharge summary of something along those lines, that can be very helpful for us to be able to glean a lot of information. And then we do like some help in terms of trying to sort out the focus of the referral, because I think as Betty Lou's case illustrates, there are a lot of different avenues that we can approach these things, and we want to make sure that we're focusing on the areas that you feel are of major concern to the patient and you as a provider or referring source overall. Sometimes there can be challenges in terms of sorting out if this is the right way to go for the patient, or eligibility, or other issues like that. Two of the most important people, or three of the most important people in our program actually are our navigators, who basically are available pretty much continuously during business hours to be able to address the question of whether this would be an appropriate person. And they will be the folks who, by and large, do a lot of interfacing with you around the patient's care. So as I mentioned, we're very privileged to have a large and very stable and growing group of folks with deep expertise in palliative care. Overall, I'm not going to bother list everybody's name here, but many of them I think are well known in the larger medical community here in Central Maine and other parts of the state, basically because of their training and their expertise in hospice and palliative care. We've got 4 super fantastic nurse practitioners who are all very experienced and really great at this work. And Kathy serves so capably to help provide some direction to our social work resources, and as I mentioned, 3 fantastic palliative medicine navigators. That's Lori Dyer, who previously mentioned, our nurse. Kathy Alexander, also a nurse who does a lot of inpatient navigation for us, and Bree Genschel, who's a social worker by background, who also is very involved in navigation in the program.
So we're going to go back and visit with Betty Lou here and see what happens to her, and let you know kind of right up front, this is Betty Lou's journey. This does not mean that it's everybody's journey that comes to us for palliative medicine. We have a wide variety. It's just this is her journey. So once this referral comes to us, and we set up a meeting. She has a call from Bree, and Bree tells her a little bit about what to expect, and sets up a schedule meeting with the provider, who does usually that first visit. We hope to see people in person wherever they are. Sometimes it does. They're open to a virtual visit as well. People are invited to come from the family, and so Betty Lou's son comes, and she states very clearly during this conversation that she does not want to go back to the hospital. She's sticking with that. She's staying pretty close to that. And the practitioner notices that the advance directives, and took your referral and knew that those needed to be updated, and updates those advance directives. Some details in those advance directives around what Betty Lou understands about some of those life-sustaining treatments. If she were to be resuscitated, what might be some of the things that might happen to her. And it goes through some of the wishes and the goals and the beliefs and desires of Betty Lou, and gets those written down and updates the advance directive. The providers also kind of is hearing that, boy, son says, if somebody signs a DNR, people just won't help them anymore. People won't pay attention, especially with that hospice. If we get that hospice, if we get onto hospice, people just give up. We hear these comments. These are the myths, of course, about if somebody as a DNR, we certainly are going to be helping people. Having you're not being full code just means I don't want to have all of the aggressive, heroic measures to try to get my heart started beating again, and my breathing started again. And so they're having this conversation, and they all decide and agree that maybe it's a good thing to learn something about hospice. We're not ready for hospice yet, because Betty Lou kind of thinks she doesn't want to go back to the hospital, but boy, if something started to go wrong, she'd sure want to maybe go back to the emergency room. So she's not ready yet for hospice, but they agree that it would be good to learn about it for down the road. It's been a long conversation, and the provider's thinking about getting a pulse done, but they decide, I'm going to come back in a couple of weeks, and we're going to review this pulse and think about everything we've talked about today, and then I think we'll be better able to complete that pulse. And the practitioner then updates Lori Dyer, and she's our navigator, right, in our outpatient world, and says, Lori, I'd like you to follow up with this patient by phone on a regular basis. And Lori sets up, and she is very organized. She's got things very set up and ready with how she's going to do those phone calls. And she begins to develop that relationship by phone. And we're finding how absolutely critical that is. So that's what would happen to Betty Lou. The next slide finishes her story with us. So the palliative care team continues to provide the services for several months, and it can be months. And we have goals that we set up. We provide her with a social worker. We might provide her with spiritual support, and kind of having more of those conversations. The nurse practitioner does continue to monitor symptoms and makes the recommendations to the PCP for the medications, because it's important that our nurse practitioners, our physicians are not going to prescribe. We're going to coordinate with you, with your palliative, your primary care physician. And so there's a lot of good communication that's flowing back and forth. And we're going to make sure that those documents that we have done, like that pulse that does get completed, we are going to make sure that you have a copy of that the hospital that Betty Lou goes to has a copy of it. So we're doing a lot of that coordination and communication. And, we're making these recommendations. Betty Lou does decide, now, if I don't want to go back to the hospital, then I better, have a DNR in place. And that's posted in the home, and And those pieces are done as well, and they understand to take the pulse with them if they do decide to go to the ED for something. But then Betty Lou goes to a cardiologist, and she gets all these test results back, and her ejection fraction, or how her heart's beating. Is that right, Vance? Being a social worker, and that ejection fraction when the heart's just not pumping so good? Something like that. It's something like that, but I would say it plainly like that. And that she's also getting some more of those symptoms, her swelling starting, and you know, she's now knows her palliative care team well, and there's a conversation about a hospice again, and there's a conversation about that benefit, and they're remembering that information that they have and received before, and they decide, and Betty actually decides that she is ready for hospice, and that we help with that transition of care to hospice so that that is a nice smooth transition for her and it's not complicated. So I'm going to turn this back over to Jillian now. And for our conclusion today, I want to thank you all so much for being with us today. Jillian?
Yes. Thank you, Kathy and Dr. Brown, for that enlightening presentation. We have been receiving just a few questions from our audience, so it looks like now would be a great time to dive into those. So our first question is, will this presentation be available afterwards? And the answer is yes, this will be sent out afterwards. We will also have a recording that we'll be able to distribute afterwards for you to share amongst your teams for anyone who wasn't able to join us during this time today. And another one we have that I am going to defer to Dr. Brown and Kathy is, can patients receive palliative medicine while also receiving home care or other service programs?
Sure. The answer to that is absolutely so. As a matter of fact, sometimes one of the things that the initial source of referral for information is oftentimes a home care nurse who's dispatched to help assist a patient in the home, and discovers that they're a lot more than just recovering from post-operative from a hip pinning or replacement, that they have a lot of other challenges that need to be sorted out. And so they absolutely can receive those concurrently. What they can't receive concurrently is hospice care and palliative care, or hospice care and home care. As I mentioned, hospice is a very unique benefit that's essentially kind of carved out overall.
Well, that actually leads very well into our next question, which I know we dove into a little bit. What made you decide to choose palliative medicine for Betty Lou instead of going directly to hospice?
Well, Kathy might have her own opinion on this, but I'll share mine, which is the hospice conversations can be challenging, and as we talked about, the patient and their family and their support system have to be confident about their decision overall, and that decision involves real clarification of the goals of care ahead of time. So I think it's a great chance for a patient like Betty Lou, who is somewhat ambiguous overall about what the directions of her goals of care are, to have a hospice, have a palliative medicine team, for want of a better term, precede some of that discussion overall. And sometimes these conversations take place not only over a large block of time at one setting, but they also require longitudinal follow-up conversations, and people need to process these things. Particularly older folks need to process these things. Usually when they've made up their mind and the family's made up their mind, it goes much more smoothly than trying to have a conversation where hospice may not be the clear goal at the start of the conversation, to make sure enough time and space is given to that to make sure we've got it sorted out.
Thank you.
I would just add that there were some goals that needed clarifying, and there were some myths that needed to be worked through, and so we did recommend the hospice talk just for information. And she also still was not quite ready to give up going to the emergency room. And her son clearly wasn't ready to give up that. He was not quite there yet. And I want you to remember, he just lost his father, right? And so he may have been dealing with a little bit of, wait a minute here, slow this down, because I'm not quite ready to lose my mother too. And Betty Lou, though, was feeling like, I don't want to have an experience like what happened with my husband. It was not a great death in the hospital. And so there was a lot of things to sort out. And there was a lot of symptom management that could be done, and maybe a little more of the PT might be working if with symptoms were managed a little bit better. And maybe if she was not so short of breath, she might actually make some gains with PT. So it's sorting some of those things out is absolutely a critical phase that happens before people go on to hospice. Thank you.
Thank you. Oh, and it looks like we have one more that just came on. What is your process if someone is on a ventilator? Can they be on your palliative program with that?
Yes, they could be. Clearly, some of those decisions about for patients who are on long-term ventilation can be really difficult issues to sort out, we're happy to assist with that. Obviously, sometimes some of those conversations are very challenging in that the patient may be contemplating active withdrawal of that life support supportive treatment. And we're clearly used to working with that type of population overall, so we would welcome those type of referrals if need be.
And we have had many also. We have had, and it might be that Kathy Alexander's, the person's in the hospital on a ventilator, right? And she's going in the hospital setting as our RN navigator, working in the ICU with folks who are ventilated. But there are folks who go on life support and live, I think of ALS patients that I've treated in the home, and the conversations that went on to try to figure out, because once you start a life sustaining treatment, it's really hard to stop it. Dialysis is another one. We have Cynthia DeSoy. We are so happy to have Cynthia join our medical team. She is a nephrologist, and and she's also a palliative care specialist. So she really can navigate those kinds of conversations about when would dialysis make sense for you based on your goals of care or what's happening with your health to decide when to stop dialysis. As ALS patients, same thing. When does quality of life shift for you? What did that look like? What would be happening different that might be time that you would want to decide not to continue the vent support? And how would it be that we make that transition for withdrawing care? Those are, as Vance said, those are complicated things, and the palliative care team are critical involvement in that. Those conversations.
Absolutely. Those are definitely important questions to have, and definitely takes the right people to have them. So thank you, Kathy, and thank you, Dr. Brown, for that. It looks like that covers the questions that we have for now, but if you're like me and you think of questions after our time ends today, which is wrapping up right about now, please do not hesitate to call or email your business development specialist or provider relations consultant, either Sarah, Sean, Lisa, or myself. We are always here to help you help your patients in any way we can, and we want to know how we can be of the most help to you when it comes to palliative medicine. So really quick, before we end our time together and move on with our afternoons, please take a moment, if you will, to answer our final poll question. What information gleaned from today's webinar would you be most interested in following up with you after today? Well, it looks like we have some of those answers rolling in. We'll leave this up just for another moment or two if you're still doing that. But thank you all so much for spending your lunch hour with us, and have a phenomenal rest of your day.
Thank you all.